But anyway, most of you know me. I'm Robert Cartwright from the Institute of Classical Osteopathy, and this is Chris Campbell. And so, okay, without any further chat from me, I'd like to pass you over to Chris Campbell.
Hi.
Hello, Chris.
Okay. Good evening, everybody. I'm hoping that, this was supposed to be just a little bit of light entertainment, but it's got a bit away from that when I looked at it in more detail. So I hope you get something out of it. I'm going to try and share the thing now. So if it works, okay, is that? Oh, I have to hit share. There we are. So you can see that? Yes, yeah. Perfect. So it's about the common lesion pattern. And we used to hear this all the time from Wernham and his writings and his talks. And he used to say that the physiology varies infinitely, but the mechanics never vary. And as students, we used to get quite confused about this as to what he was talking about and the position that he was taking. So I'm going to go through what he said in his writings first, and then look at some other people's writings about it, and then see if we can pull it together into what it means in terms of osteopathy, and particularly classical osteopathy. And we find that there's a number of different versions of this. You get very different snippets, like in anatomy books, that there's a convex lateral curve in the upper thorax. Some people say, like Gerdish, probably due to greater muscular use on the right-hand side. Wernham, again, saying that the mechanics never vary. Greenman saying that authors have referred to a common universal pattern, commonly noted in papers, and all of these things have a function and it keeps coming up, and yet every time you come about it, it seems slightly different in the way that it's talked about. So it can be confusing. And then what does it mean? What do we do with it? Has it any value? And there's a little video clip that Wernham gave when he talked about it in a particular patient. And I just want to show that to begin with, and I hope the sound on this works for us. Now, I've often, the physiology varies infinitely, but the mechanics never varies. The same in every patient. Now, that's a tough remark, but it's true. And I want you to palpate it in this patient. It's not very severe in this patient. He's a strongly built man, but the symptoms are there. And you all find that the slope is that way, never that way. And it goes round the third, which is very anterior. And then it goes, and then it twists about. It's always right here, to the left here, to the left here, and to the right here. Now you can check that for yourself on every patient you see, and you can check it on this patient by palpation. The other thing I note carefully, would you stand sideways to me? Is the posture. The slope in the anatomical position, and to all intents and purposes, the sacral, we know the sacrum is not, but it feels, there are two planes like that, you see. They're both vertical. Probably vertical, just for the family. This one is truly vertical, should be, in the organism. This is not, is it? And the other thing is the protrusion of the erected, the abdominis, rectus abdominis. This is these two here, What do you call them? Rectus. The two reptile. Reptile take the rep. That's pressure on the yeah. Let's look at that in a bit more detail, just because he's gone through it fairly quickly, and see what he says. He starts off with the slope. And this confuses a lot of people because they can think of that slope as being the slope of the baseline. And we'll come back to that. That's always in that direction. Then the third lumbar, around that it's convex to the left. Then in the upper thoracic one, convex to the left, convex to the right. And then in the neck, convex to the left, and then continues up into the skull, where you get that bulge on the right, the right temporal. And this is the pattern that he says is almost invariable. And in the middle here, twists and turns about a bit. So, what does that mean? And is it true? And is it consistent? He starts out by talking about the victim of a non-parallel line of force. The movement is always to the right and suggests that the liver is responsible for that. And the weight of the liver moving the center of gravity over to the right if there is a non-parallel line of force. And that's what he's talking about between the sternum and the sacrum in the AP plane, but also then in the lateral plane. So you have a gravitational thrust into the right iliac fossa, and you get a flared ilium. Fried called it dish denominate. So it flares out, moves up and anterior on the right. And the left then moves in the opposite direction. And with that, we also get tense inguinal ligament on the left-hand side and the tensor fascia lata on the right. Now these diagrams, this is a lovely one from a lecture that Chris Campbell gave, but sometimes it becomes confusing when you see a diagram and you're wondering, is this looking face on or is it looking from the back? And then we get confused about lefts and rights and so on, and we have to remember what is what. The liver here sitting on the right, you get that force down non-parallel line, instead of going through the center of gravity, moves over to the right. Then if you look at these sides, the left-hand side, completely different. The nominal has moved upward and outward. The inguinal ligament is tense, the tensor fascia is painful, and the three adductors offer the most resistant. Movement is difficult in contrast to the right, which is freely moving, but the effect is that the baseline is disturbed by the torsional stress in an upward direction to the left. The rigidity on the left gives the view that it was the primary condition and the right was secondary. But Wernham says he thinks that's the opposite. Paul always said it was the left as the primary. Wernham used to say that, and then he changed and you know, became a bit more ambivalent, giving both views at different times. And again, sometimes we get confused by how things are written. The anomaly has moved upward and outward. And we have to stop and think, what does that mean? That means it's moved posterior. Yeah. And Littlejohn, in his descriptions of it, was you had to really sit and think through every movement that he described as to decide what he was saying. And almost on a quick reading, you'd think it was the opposite. And that leads to even more confusion. And he says in this one that the first spinal curve is formed to the left of the center of gravity. And then you get this series of curves in the spinal column. And the pattern is unmistakable. The second to the right, the dorsal lumbar junction, involving the dorsal lumbar junction. Then to the left in the lower half of the dorsal, and to the right in the upper half. And the convex the junctions are always sensitive. And then you expect the cervical spine to be convex to the left, following this pattern of curves. And then it continues up into the cranium, and you find the right temporal bone is prominent, and the occiput then sitting uneasily on the atlas with a rotational tilt opposite to that you find in the pelvis. And he carries that further into the clinical findings that the TMJ, the mandible, always swings to the right, never to the left. And this he bases on his own clinical investigations over many years, and he invites his students to go and look at it for themselves. There's one thing I'd like to draw attention to here, and that in this lecture he's talking about short lateral curves, and I'm going to come back to that because that again is key to understanding what he's talking about and key to seeing the pattern that is actually there. In another lecture, The Art and Science of Osteopathy, he said, again, left lateral movement in the cervical, right lateral movement in the upper dorsal. Lower dorsal movements are irregular. In the lumbar spine, the deviation is to the right, which is the opposite. Consistent almost apart from that last one, the movement is to the right. At this point, students get very, very confused. They say, okay, which is it, right or left? And if it goes to the right, then should the other curves be reversed? How can they be the same if same direction if the first curve is in the opposite direction? Yeah. Pelvis, the same thing in the pelvis, anterior right, posterior left, with the sacrum torsioned within that. I was used to come when I was in clinic in Maidstone, and students would come out and say, oh, they find the opposite pelvis. And you go and you check with them, and you'd find that they hadn't. Wernham was very, how do I say it? I think he was very annoyed about osteopaths who couldn't find a lesion. They could find simple tension within the body, but they couldn't find an underlying lesion pattern. And they'd find just mix up the way the spine had twisted or the pelvic girdle had twisted, but not the lesion underneath it. They'd find the way the shoulder girdle had twisted, but not the lesion pattern underneath it. And they'd mix up these things. Then the cranial lecture on the cranial technique, it goes through the same thing. Base at the baseline is tilted. Reciprocal action at the center of gravity at the third lumbar. Excess asymmetry will be sidetracked and cause the lumbar spine to curve laterally up to and including the third. Then he adds in another piece of mechanics, the double arch, that's central arch 2D to 5D to 2L, which is supported on the center of gravity, it becomes unseated. So that's the powerhouse in the spine, and it becomes unseated. And when it becomes unseated, the whole sympathetic side of life within the body, the powerhouse within the spine, becomes unstable in some way, and the body has to find a new balance within it. Then he goes on to say that the curves, first to the right in this time, then to the left around the keystone, and then the upper dorsals to the right, left in the cervicals. So again, there's confusion about what that first curve is happening and what way that baseline is tilted. Otherwise, fairly consistent. And again, he emphasizes here short lateral curves. And keep that in mind because we come back to that a couple of times. And he insisted on bringing this up into the cranium, which it does. It has to from a mechanical point of view. The temporal bone, you get that right bulging on the right-hand side, the left being a little bit more flattened. So this baseline always moves in the same direction. The short lateral curves are similar in every patient, and the temporal bones behave in the manner described. Very big statement, as he said. If everything is consistent like that, how can this be no matter what patients go through in their life? He gave another example in a leaflet that he produced showing a X-ray of the spine. And again, is this from the back or from the front? Which is left side, which is right side? He says he's looking at it from the front. And if we're looking at that from the front, the curve is to the right. And this is where I want to come back to this thing of the short lateral curves. If you look at this spine, these are not short lateral curves. These are S curves going all the way up. And they're different. Those sort of S curves are the, if I'm going to use the word, the primary compensation for a tilted baseline. The short lateral curves are something slightly different. So, having gone through all of that, and remembering myself as a student at this point and going over this with fellow students and trying to reread things and trying to play back, well, what did he say this time? What did he show on the patient this time? And you'll be demonstrating on a patient like that video that we just saw, and pointing out that it goes to the right here and to the left here, and the student were looking at it and said, what goes to the right, what goes to the left? Is that spinous processes? Is it the bodies? Is it the posterior rotation? And we almost would give up. It was so confusing. An old student back in that time tried to make sense of it, and going back to the Littlejohn's description of it using the ship's mast, which has a keel and deck, and then the shrouds and the stays holding it in place. And he drew it with the baseline, sacral baseline, tilting this way, giving you a curve to the right, and then these long, slow curves that you'd expect from that. Now, if you think of what happens in a ship's mast, now it's a fixed rod going all the way up. It's got these shrouds and stays that are holding it and balancing in place, stopping it from moving vertically and from side to side. If that baseline becomes unseated, you're going to get a series of tensions all the way up. Now, engineeringly, if you try to just reseat that at the bottom without paying attention to these shrouds and stays, you're likely to break something at the top. And it has to be done a little bit here, a little bit here, a little bit at the bottom until you get all of that back into balance. And one of the important things that I want you to keep thinking about is you've got a tilt in the baseline. There has to be this series of lateral curves come from that. But what happens to lateral curves? What happens to the body? Does it stay like that? It's a living person. The mechanics are physiological mechanics, they're living mechanics. The vital force and everything in the body tries to come back to the midline. There's going to be changes and compensation within all of those. And when we were taught to look at a single lesion and we look to say which way is it side bent and rotated, we wouldn't stop there. There wasn't, is it side bent to the left and rotated to the left? And then the next question is, which way is it side bending? Is it still side bending to the left and rotating to the left, or is it now side bent to the left and beginning to try and rotate to the right? You know, it always tries to find its way back to the midline, unlike a rigid structure like a ship's mast, in which case you only get the tension in the shrouds and stays. So those long lateral curves will be converted into short lateral curves based on whatever other lesion conditions there are in the spine. Which brings us back to this point, did he mean right or left? Now the picture on the left here is taken from a screenshot from what he had drawn on the board during this lecture about the cranial technique. And if you look at it that way, you say, okay, this is convex to the left, the way he had drawn it. And it looks that way. And then you ask yourself the question, well, what was he trying to say? He was actually talking about these things continuing up into that side, continuing up into the cranium. When he walked away from the board and he explained it, he said the bulge on the right, which puts it into perspective. And we tend to sometimes, particularly when somebody's talking, to get caught up in the irrelevancies of individual words that might be used and forget that, well, we can get words mixed up. We can say left and right and in the wrong way. We can draw a diagram in the wrong way without realizing it, instead of hearing the important points that have been made. And the two important points that he was making in all of these is the effect on the third lumbar, and the curves also continuing up into the cranium, that the mechanics don't stop at the top of the neck. And underneath all of this, we have the baseline. The pelvis is the base of the body. And we'll come back to that again when we look at what other people are saying. But let's go back to this unlevel baseline again, because this is another important point. And he always shows it in that direction. And where are his thumbs? What is he actually moving and or listening to? And that is this posterior superior iliac spines, not the sacral base. Posterior superior iliac spines. So you have to ask yourself, where are you putting your fingers? And this is an exercise I'd always give students and try and get them to replicate. Where are you putting your fingers? Let's see what happens. In the PSISs, and they bend forward, simple bending forward. The right side goes up, the left side stays where it is. Now, watch my fingers. Tiny little movement of the fingers, more medial, and you get the opposite result. You're talking about a millimeter of a difference. Go down to the inferior ones, and you get the opposite on the inferior spine. The left going up, the right staying. And you move your fingers in just that millimeter again off those onto the sacral attachments. And again, you get the opposite. And that's so important, knowing where your fingers actually are and where they're going. And again, that used to confuse students, and they just slap their fingers on and they wouldn't know whether they're on the PSIS or just even a little medial to it or more lateral to it. You have to be absolutely precise as to where your fingers are and to listen. Let the body do the movement. So let's come back to this drawing of in this case, we're talking about the liver and the uneven thrust of the weight coming down into the sacrum. Always on the right, and they're saying maybe that the liver is responsible for this. And it asks the question again, as Wernham said, that Paul always insisted the left was the primary. Wernham said, well, maybe it's the right. And Wernham would say that the right side moved more freely than the left. And yet, when you pick up a right leg to articulate the pelvis, it's half the time as rigid as iron. And we mistake the muscular contraction and the control from the patient for the rigidity within the pelvis. And again, that's again knowing where your fingers are and where the resistance is coming from. So I just want to digress a little bit on that, onto these words, primary and key lesion. Because our point of view is different. We've got primary and secondary. And this is taken from Carl McConnell in 1915. And here talk about the primary lesion is anchored, is usually confined just beyond the physiological movements, although no doubt in certain experiments it may be fixed or confined within them. Secondary or compensatory ones are fixed within the range of normal movements. And he says that many people mistake one for the other, mistake the secondary for the primary. And this is a traumatic lesion, if you like. If something happens, you get an unseating, say, for example, of the sacrum, and you get all these curves that come as a result of the secondary ones. The secondary ones are always within the physiological movements. And this is primary in relation to a particular pattern of lesioning. Then we have what's called the key lesion. Again, from his article on the standardization of technique, he says there are one or more key lesions which, if unlocked or released, will so condition the rest, secondary or compensatory lesions and mechanical changes that comparatively little attention is needed to these. Key lesion in the glossary of osteopathic terminology is the somatic dysfunction that maintains a total dysfunction pattern, including other secondary lesions. And that leads to the thought of, well, let's go find the key lesion and do something to it, and everything else will take care of itself. And this was Schuster, again, talking about, taking Carl McConnell's words and talking about it in terms of the key lesion as he understood it. And he adds in this thing that to a large extent, the art of technique to still, as we understand it, means precise detail work to every single lesion. And then he repeats what McConnell said about the key lesion. So that what he was insisting then that you do is first identify the key lesions. Yeah, identify them. And he described, again quoting Carl Philip McConnell, saying, still teaching to examine most carefully from the head to the feet to proceed to adjust what is wrong. And then he puts this forward as you find the key lesion in that pattern, you do something to it, then you find the next key lesion that's expressing, you do something to that, and so on until you can't adjust anything more. And it reads as if this is the way that Still worked. But yet, if you read what was said about Still, he would take 3 months or 6 months to adjust a pelvis or a hip. He would tell people like Rabbit, don't expect any change in your condition for 3 to 4 months, even with treatment every twice a week. It's not the thing of finding a key lesion and doing something to it, find it, fix it, leave it alone. As Fryatt used to say, find it, yes, but before you fix it, make sure you found it. Before you leave it alone, make sure you fixed it. All of those statements seem to imply doing something specific, something, oh, we'll use the word spectacular, not taking months of work to get there, months of it. So these concepts of primary, secondary, and key lesions, I think have been, and Wernham used to think, has been taken totally out of context and mislead people into thinking, okay, the pelvis is the problem here, let's just adjust the pelvis, or the neck, or the old hole-in-one technique of let's just adjust the atlas and hope everything else fits into it. Leave it to nature to clear it up after you've done the adjustment. Littlejohn in his writings would say he'd have nothing to do with this at all. He would say that was totally the wrong way of teaching or wrong way of practicing. Yes. Wernham put this into context, talking about the great battle between the general and the particular, between the long lever and the short, between the limited and the greater concept in osteopathic practice, and the realization of the desire to employ the power inherent in osteopathic technique to work with Dame Nature, to work with the vital force. And he put a lot of it down to the fashion to obey the dictates of medical opinion. And medical opinion, if I can be critical and talk about Syriacs, he invented a thing called the diagnostic sieve. You go through a series of tests all the way down to exclude all the serious illnesses. And if you got down to a certain point, then it must be amenable to, the lesion must be amenable to manipulation. 2 to 3 adjustments. If it didn't cure in that time, then it was psychosomatic. You don't do anything until you have a diagnosis. Dublin, who used to teach in the London College of Osteopathic Medicine to doctors, used to say that in the beginning, when he started teaching in the 60s, doctors weren't too bad. 70s, he started noticing these people coming in who were asking about tests and test results. The end of the 70s, early 80s, he said he had to take the doctor's hand and say, you're allowed to touch the patient. He said, no, they wouldn't do it until they had all these test results. They ended up treating test results rather than the patient. And how often do we find patients who've gone to hospital to consult and so on, nobody's ever looked at them. They ask them, how are you doing? Here's the test results, and they just keep on going like that. That is not osteopathy, and it's not the way that we should be working. The other side of it, sometimes osteopaths divulge into the other side of it and say, okay, I'm not going to ask the patient what's wrong, I'm going to examine them and then tell them what's wrong, which is almost as bad in the opposite direction in my view, but that's another story. Wernham goes on to say, it's not infrequently argued that the short thrust technique is equivalent to the long lever method, that it is specific, avoids the apparently somewhat vague approach of the limb leverage technique. The point at issue here is that treatment aimed only at the bony structure is still at the mercy of any mechanical or physiological malfunction that may be at large. The difference in technique and policy is so marked that on the one hand, we have a thrust to the key lesion, and I use the word thrust there advisedly. It's not necessarily a high velocity thrust. It can be a very simple positioning technique to the key lesion, which is another way of introducing force to release it. while on the other hand, the key lesion is carefully avoided, the purpose being that of provision of an improved environment in order that the key lesion may be rendered more comfortable and therefore allowed to resolve. And he says that's the meaning of integration. I'm hoping this will, the sound on this will be okay. We can try it and see, and hopefully it will.
I have a number of silly drawings to give you, but I hope they'll give you some idea of what it's all about. If I draw an organism in that way, it's not bad, is it? Now, if we look upon that as a break in the continuity, as I said, that's what the lesion is, a break in the continuity of tissue. And talking of tissue, I've said here somewhere, I will say it now, that the bony correction is nothing. You get used to that. But the change in the tissue never ceases to thrill me. The change in the tissue. If that is a break in continuity, then it will reverberate round and round and round. And keep going till it gets down here. But here it's very faint, scarcely discernible. Now, if you're prepared to strike that mighty blow, short range, HVT, high velocity technique, and make it join up, that's fine. But it won't stay there. It can't, because these boys are hitting back. The unstable equilibrium. And sooner or later, this will open up again. If the patient comes back and you repeat the process and join it up, the process is in a jumble like the computer I was talking about. Nature doesn't know where she is. This is a jungle, a physiological jungle. No, this is where you begin. Very quietly, very tentatively, and very slowly. You see, this is the least entrenched, the least vulnerable, the least serious, the later development. And you then begin to trace your way up and up and up. And the sign that you're doing that is contained in one simple sentence from the patient. I feel better. They may have some pain, they may have disorders, they may have this, that, but they feel better. That means the physiology is overbearing the pathology. And so you go up here, and you go up and up and up until this is secure, and the continuity preserved. That is integration. I'm fond of saying there is only one osteopathy, not two. How you do it is your business or somebody's business. But it is the only way to satisfy the claims of Dame Nature. I'm very conscious of Dame Nature. A woman, you notice. Standing behind me, cryptic of eye. Now watch it, Wernham. What are you doing? Everything I do is in conformity to the woman's whims. I mean, nature's design.
Oh, right. What he's saying there is that you start at the furthest point away from it, the least entrenched. And very slowly with your articulation workups, you're doing a little bit. And this is the beauty of the body adjustment that we do. We start on the right-hand side for a particular reason. And we do a little bit of work there, then we carry that up onto the arm and back onto the left and through the whole body, taking that little bit of adjustment that we do and integrating it and getting the response all the way back. In the same way as we're talking about the ship's mast, if it's unseated, you don't just hammer the seat of it back, otherwise you get a reaction up in the upper part of the neck for the tension in the shrouds and the stays, and that'll probably break. You may adjust a little bit, release the tension up here that comes about from that, release that a little bit, and so on. It's the same that we do in the body adjustment. But it's important that concept that we have, instead of what Schuster was talking about there and McConnell about going to the key lesion and unlocking everything, we do the opposite. We start in the opposite way. It doesn't mean we ignore the key lesion or we pretend that these aren't secondary effects. We work back from it to that lesion and integrate the changes that we have one step at a time. So anyway, you want to get back to this common lesion pattern from that digression. And this is, to me, one of the most important things that confuses most people. He talks about the slope always being from right to left. That's the slope of the PSIS, always running that way. The sacral base, on the other hand, runs the opposite way because you're getting this left-on-left rotation, and the right sacral base is dropping forward and rotating to the right. And that asks, what happens here at the LS? Does it go to the right or to the left? Which way does it go? And that depends on a number of factors, which may answer this question about the right and the left as to what he means by it and what he's talking about it at different times. So let's see what other people say before we come back to that, about this common lesion pattern or the common compensatory passion. Schamberger is a physiotherapist and a marathon runner, as far as I can remember. Drew it both ways, left and right, and talked about it in terms of the short leg and the long leg. The anterior right pelvis giving you a functional long leg, the posterior left one giving you a functional short leg. Osteopathically, we look at that differently. It isn't the thrust from the leg up, but from that the legs are suspended from the pelvis down. And then you get a secondary reaction back up from it, which is different from looking at the leg length as being primary. Greenman, very close to what Wernham is saying. Anterior right innominate, posterior left, right inferior symphysis pubis, left superior, left on left forward sacral torsion, lower thoracic scoliosis convex to the right, left lumbar scoliosis, anterior inferior right shoulder, and a left cervical scoliosis. A fair amount of agreement in general with what Wernham is saying. But he also puts it into a bit of a context by talking about if the patient's dysfunctions are out of this pattern, they are more clinically significant. So if this is an underlying pattern, if I can use that term, if there's something out of that pattern, it's pointing to something else has happened to the spine or something else that pattern has run into. And from a functional point of view, a physiological point of view, they're more important. So he also talks about, in addition to the articular restrictions, there are consistent patterns of asymmetry in muscle function, with some muscles becoming tighter and others becoming inhibited and weak. And he describes them in another part of his book. But here is the danger. Wernham was adamant about avoiding this danger. The presence of a common universal pattern can result in practitioners treating in a cookbook fashion to restore motion to the segments in this pattern. And this is why Wernham insists that you do not copy what he's doing. You understand the principles in the body adjustment. And routine, properly applied, leads to a finesse in your ability to see what is happening within the body and to adjust it. It doesn't become boring and lead to this cookbook fashion of what you're doing. It has actually the opposite effect. Routine, properly applied and properly thought out with attention, leads almost imperceptibly into the world of rhythm That's how I put it. It opens up that whole field of the rhythm within the body, the rhythm within the nervous system, the sympathetic nervous system, the cerebrospinal, the rhythm within the organs themselves, the rhythm within the within the cavities within the body. All of that suddenly opens up to you. It's like opening a window and having a look out into the fields beyond. That only comes when that routine is used properly, with attention and with the ability to understand the principles beneath it. Greenman also goes on to say a number of theories have been postulated to account for this pattern. He goes through a number of them, like the Coriolis force of gravity, so that you expect the opposite pattern in the southern hemisphere. And he says he's treated in both hemispheres and found the same pattern, so he dismisses that. Then you have the right-handedness, which is a bit more plausible, because a high proportion of people are right-handed, and the left-handed people have to live in a society dominated by tools and equipment that are made for a right-handed. So again, it could be a pattern in it. And he's also then wondered about the birthing, that most children are delivered with a vertex presentation of the left occiput anterior, and that might have them. They're just theories, in the same way as Wernham's mentioning the liver being part of the weight of the liver on that side. But if that center of gravity line has moved to the right, and then the liver's weight has carried that thrust down, something must have started that process. Something else has started that process somewhere. And that, shows a question mark over right or left as being primary. Something else may have started it before that. And this whole idea of primary and secondary, well, it has a use, is in the same way as a key lesion has a use, but it isn't the be all and end all. And we can spend too much time looking for those things rather than working with what nature is trying to do. The vital force is always trying to bring the body back into better balance and to give you the best it can do, given the lesion state that the body's in, the environment, and most importantly, the vital force interviews you as an osteopath to see, well, what are you up to and how do I work with what you're giving me? If you're trying to push and pull it around in your own way, the vital force has to accommodate to that. Or if you're not listening to it and seeing and having that dialogue with it, you get a very questionable result otherwise. Hoover and Nelson, in their article, said, in the pattern most frequently found, the convexity occurs to the left or the right side up to some point in the dorsal spine. So they don't come down either left or right in the lumbar spine at all. And then upper dorsal to the opposite side, the cervical commonly the same side as the lumbar. But he also puts it into the context of individuals accommodating to imbalance produced by compensatory curves, and is determined by the limitation of motion imposed by existing lesions or positions. And this is what I mentioned earlier about these short lateral curves as opposed to the long curves. The long curve from a tilted baseline is your, if you like, your immediate compensation. But as that tries to happen, it'll run into other lesions. The lesion at the third lumbar, which has to be thrown off because of the movement of the center of gravity, other strains and so on that'll be there. And also the adaptation of the body trying to come back to the midline. And that'll convert those so-called long curves into a short series of short curves that Wernham is talking about. And the short lateral curve is physiologically much more important and much more difficult to deal with. And as you start working through this with an individual, and we were privileged to see Wernham doing this over 4 or 5, 6 years with a patient, and you see those short curves being converted back into the long curves and then eventually back into a beautifully balanced spine. And to some extent it looks, well, it's not straighter anymore, it's more curved, maybe it's worse. Whereas actually you're retracing the step, as Still used to say, that the body doesn't jump back from a lesion state to a non-lesion state. It works slowly back through all the patterns that has happened on the step. It retraces its steps back. Another thing which is often mentioned is the effect of the aorta. And in all the books in anatomy, you'll find this, a short lateral curve to the right in the upper thoracic area. McConnell says from the fifth to the second or third lumbar, slight physiological lateral curve. He's talking about as a long one. Yeah, he puts it down to right-handedness. Gurish puts it down to the right side, overuse of the muscles on that side of the body. Fraser goes into more detail about the impression that the aorta makes and how it does, and this impression is best marked on the fifth body, but maybe followed down for 2 to 3 vertebrae. In other words, a very short curve, finally fading at about the 9th segment. Another author came across this and was wondering whether it was due to the aorta and the pulsating forces of the descending aorta. So he went and looked at a study where he would look at dextrocardiac patients and levocardiac patients where the heart was on the opposite side. And he found in those patients, the dextrocardia ones and the levocardiac ones had a convexity to the opposite sides, indicating that yes, the aorta may play a part in that. You know, the aorta does have that effect. So again, that might be part of the problem. So, comes back to another point. Whoops. The baseline itself, the sacral baseline, it's a very variable component. Yeah. In structural pelvic function, Mitchell talks about it being formed convexity to the left or to the right. Lumbar curve, convex to the right with vertebral bodies rotated into the convexity or to the right. However, he says, this depends on the facets. If they're sagittal, facets of the LS, sagittal being thoracic, will rotate in the same direction as the sacrum. Or sagittal, sorry, is lumbar type facets. If it's the coronal ones, which are the lumbar, the thoracic ones will be rotated in the opposite direction. So you get a different curve depending on why the facets are. Fryatt in his book on technique give beautiful pictures of these. Where is it? Okay, just before we go on to those, just to mention again this idea of first, second, and third degree compensation to a sacral base. Just drawing it very simplistically as being sacral base to the side bend to the left and the convexity to the left. The bodies, as I said earlier, and the vertebral always trying to rotate the body, trying to bring it back to the midline. Always. So and when it does come back to the midline, it isn't that it's easier and straighter. These will be much tighter and more restricted in general in a second degree lesion. And then it'll overcompensate to the other side and it'll oscillate back and forward until you've got a totally rigid spine unless something is done about it. So, and understanding Fryatt's laws in this is also important. You know, that the type 1 motion, side bending in one direction, rotation of the bodies in the opposite direction. Type 2, side bending and rotation in the same direction. And type 3, then, that you get a decrease in motion and all of the planes of one plane is restricted. You know? And you get these wonderful drawings as to what happens to the spine being looked on as a pile of blocks with an eccentric force going through it. The same as what Wernham was talking about, the deviation of the center of gravity line off to the right, and the bodies will try and crawl out from underneath it. Yeah, wrong way. And the second law of the sacrum will tilt basically along this oblique axis from one side to the other, the right on right axis, or the left on left axis, and it will rotate forward, which means the baseline will be tilted to, in this case, to the right. And these simple diagrams often confused because they don't actually show what actually happens in it. They give a simplistic representation of Fryatt's laws. Now, in the second, if that was moving in the Faraday's second law of the rotation would be in the opposite direction of the sacrum. And what he says, and this again comes into halfway explaining this difference in right and left and what happens in that common pattern that Wernham is talking about, that it's related to the lumbosacral and lumbar type facets. If bilaterally coronal, that is coronal, be frequently a C curve convex to the right with the vertebral bodies rotated to the former convexity, or to the right. If they are sagittal, L5 will rotate in the same direction as the sacrum. So this difference in those facets is so important in terms of what happens at the first lumbar segment up to the third lumbar. And these are the diagrams that Brad gave in his book, showing sacral base, lumbar type facets, and a fairly broad sacral base. Or sorry, thoracic type facets there, sorry. Thoracic type facets. Lumbar type facets, a more narrower sacral base looking if you're examining it. Now, how often, if you look at any spines, the ones that you have in your practice and so on, you'll see variations in these facets. Sometimes one being a lumbar type, another being a thoracic type, and they may vary all the way up to the third lumbar. And he chose the mixed ones with the thoracic type facet on one side, the lumbar type on the other. So again, what actually happens in this initial part is very much related to those types of facets. And oftentimes you get a short curve trying to go off in one direction and being forced back by the types of facets before going back off in the other direction. On top of that, then, Frad also gives these wonderful different extremes of the sacral facets, from very deep concavity to convexity and to mixed. So when we're talking about short lateral curves, remember, primary compensation, if I use that term, to a tilted base will be long lateral curves, but they will meet with opposition and tension in the lesion state that's already there from other aspects, and will be to some extent defined by the facet types at the lumbosacral junction, which may start the curve going in one direction and bring it back over to the other, so that where do you talk about? Where is the curve? And you saw in that video at the beginning, Wernham was talking about the right convex thoracic up at the top, just below that going down to the mid, having the left, and then broken into groups. Below that, broken into groups being related to that central arch, and it being unseated on its third lumbar, and then the dorsal lumbar junction, where the facets are more like a mortise and tenon joint, which again puts restriction on how that will respond to a sacral base twist. But behind all of that, there's another aspect. And just to finish off, that was Littlejohn, as Wernham used to say, looked way behind the visible body into that mysterious, unseen world of force and function. And we talk about the pelvis as the foundation of the body, the baseline, the sympathetic nervous system, and the cerebrospinal nervous system, not as so much as nerve trunks and so on, but as the nervous energy that is flowing through those. The sympathetic side being the visceral side, the cerebrospinal being the conscious, unconscious side of the body, and the development of the two nervous systems. And looking for this first effect, this sort of futile thing, let's search for the primary and then deal with it, or search for the key and deal with that, instead of saying there's an underlying pattern here. Let's work gently and quietly from, as Wernham said in that video, the least entrenched lesion back and retrace it back through its steps as to how it formed, or still used to say this jumping from abnormal back to normal doesn't happen, that nature retraces its steps slowly and quietly back if we give it the right circumstances. And we have this cycle of disease in relation to pathological states. The pathological state of the body may originate either in the sympathetic plane or the cerebrospinal plane. If it originates in the sympathetic plane, the result is it'll affect the visceral organs first through the sympathetic system. The cerebrospinal system will be involved, and the reaction will then come back just in the regular routine of cycle into the organs once more. So you have the progress from superficial to deep, circumference to center, from sympathetic to cerebrospinal and back into sympathetic. If it originates in the cerebrospinal system, it'll exert pathological influence onto the sympathetic, and then that will react back into the viscera, and from that back into the cerebrospinal. In every case, you have this cycle going on, cycling, either being kept in a superficial cycle or cycling deeper with each cycle that it goes through. And if you just apply a sharp change to it, you've disrupted that cycle, and then the body has to find a new one. Yeah. And that's what Wernham was totally against in terms of, and Littlejohn was totally against in terms of how to work on the body, how to work gently and quietly with the vital force. So it's this coordination or adjustment of these two nervous systems. The great cause of disturbance in the body activities is the incoordination or lack of adjustment. And no matter where it starts, it ends in the cerebrospinal side. And that cerebrospinal side is reflected into the right sacroiliac joint. The sympathetic is reflected into the left one. And this is again coming back to the body adjustment as being such a gentle, quiet, rhythmic movement, reimposing rhythm where it doesn't exist, taking that disturbance in that cycle and adjusting it better, and gently, quietly leading the body back to health. Why does it settle in the cerebrospinal? There's the great system which exerts control of the body in its maturity. That's the cerebrospinal side. It's the last one to be completely evolved, but it is the one that develops the highest degree of perfection, exercises the greater control of the body influences, because it also relates to the environment and the environmental lesion, as well as the emotional lesion within the person as to how they use the body and the subconscious effects within the body. So that if we look at the baseline, this what Wernham and Littlejohn used to call the primitive baseline of this triangle of the pyramids. The primitive baseline running from acetabulum to acetabulum, which is basically the cerebrospinal balance in the body. The coccyx, which is the sympathetic balance within the body. So if we get a cerebrospinal imbalance or insult, what happens is that reacts on the sympathetic system. The sympathetic system then reacts back into the cerebrospinal, and the result, we get a torsioning of the baseline of the pelvis. And we have to reverse that, and this is what our gentle, quiet articulation does. Sometimes when we're articulating, particularly on the left-hand side, we'll go up and gently take out some of the compensatory factors in the lumbar spine, and then come back to the pelvis, and it's much clearer, much easier to deal with. And with that, there's this other aspect, and this is called fetal programming. And there's a lot. It's a fairly detailed piece of research at the moment going on in that about what happens in the fetal development in utero has a serious effect later on in life. You know, whether it's simple things like toxins, temperature, substance abuse, alcohol, etc., maternal constraints, diseases like preeclampsia, viruses and so on, hormonal stresses, diet, malnutrition and so on, all having an effect later on in life in the adult on the metabolic diseases, cardiovascular diseases, blood vessel, heart, kidneys and so on. Sometimes that's what we're dealing with, as if you want to call it a primary. Not a twist on the left side or a twist on the right side, but a deep-seated strain malfunction, disorder within the development of the sympathetic nervous system, and then the cerebrospinal system coming in later trying to accommodate to it. And just to finish, a thought from notes by Webster Jones on the physiological movements, notes that he took from JML. The function of the body's vital force in its physiological sense is so bound up with and interdependent on its physical structure that there is a continuous struggle between the two. The vital force and the body structure and the physiology, continuous struggle. The only difference is to the laws and forces of gravity. They are the arbitrators, as Wernham used to say. They are consistent, the laws of gravity and the forces of laws of mechanics and the forces of gravity. Therefore, the study of the laws of physiological movements resolves itself into the study of physiology and physics with body mechanics under physics, the body mechanics under physics, and maintenance of correct function through the erect posture under physiology. So he divides it up into two aspects. The body mechanics with physics attached in it, and that's living mechanics now, not just static mechanics, and then correct function in the body, the physiological function, which is under the influence of the erect posture under physiology. And then he goes on to say that posture, what is it? He says this is actually laid down in the child's spine in utero and remaining there both before and up to the time of walking. It's always laid down very early, and this is where the fetal programming may come in. And then the time of walking, you get all the insults of walking and so on, and the effect of the environment and so on that. He says then it is the attempt to maintain the erect posture after locomotion begins that we lay the foundation of the physiological movements. And this is where this pattern, consistent pattern, common lesion pattern, common compensatory pattern, whatever you want to call it, comes into that. That's where it starts. All of those influences beforehand. The twist in the pelvis, the twist in the right pelvis forward, the left pelvis right, the interference between the sympathetic and cerebrospinal sides, where it's the weight of the liver coming down and influencing that. And built on that then, with all the other lesions that may be taking place up to that time, trying to accommodate to that strain, the vital force trying to bring it back into the midline. And that's where you get the short lateral curves, because those initial long curves disappear very, very quickly because of all the other strains that are there. And that the baby's bodies are built from their maternal tissues and DNA and the father's DNA, leaves them open to inherited toxic conditions and traits. And during the first 7 years, the change of teeth, the organs are still being developed in line with cerebrospinal nervous system influences from the environment, both physical and emotional. And sometimes you have to trace all the way back to that in trying to see if we want to try and find the so-called primary or key lesion. It's not something you can just find, let's do something to it and hope for the best. And the anomalies that we find in these short lateral curves that Wernham's talking about, the only real one there that was in it is the understanding that he's talking about the movement of the third lumbar and what happens below that being so dependent on the facets within it that it's sometimes hard to see where that can be. And that gives that rise to those occasional differences where he talks about sometimes being to the right and sometimes being to the left. In his papers. The other one is in the cervical spine. He's talking about the lower part of the cervical spine as it comes up from D2, the curve to the left and then going off into the right and into the cranium. So I hope you got something out of that. That's me finished. And I'm thirsty and tired of talking. Thank you.
Thank you very much, Chris. That was wonderful. Really, really interesting to hear that perspective and see how different authors had written different things, which added to the flavour and the confusion of it. if anyone would like to ask any questions, if you'd like to put it in the chat. We've got one from Caroline Stone here, Chris, which is, did anyone discuss that it was the 3rd degree lesion that caused the most neural distortion, e.g. into the somatovisceral dynamics, rather than the 2nd or 1st?
It's been mentioned, but it depends, and I haven't seen anything definitive saying one or the other. 2nd degree lesions, Hoover and others always talked about as being the ones which are having the most deep-seated physiological effects. And if it moves into a 3rd degree, then it's going even worse than that. So with the 1st degree being more on superficial, if I can use that word. But as it starts cycling back and forward, it's going to get deeper and deeper, more. Even if you see the spine, it gets more and more rigid in the structures and the soft tissues, the ligaments, and so on.
It certainly, from my experience, is, you know, often with the 1st degree situations, it's often more pain that people, or discomfort that people come in with, whereas when it's 2nd degree, there's often much more physiological disturbance. And I would assume that 3rd degree is just, you know, going to be even worse. Is there any other questions? There are a lot of people thanking you here, Chris. Okay. Anything else? Okay.
Well, thank you everybody for listening to my ramblings.
It was great to hear. Thank you for coming on this evening and talking to us and doing our.
The amazing thing about it is it's remarkably consistent through all the different authors. Minor differences.
Yeah.
Only real difference is down at the lumbar spine.
Yeah. And remarkably consistent when you see it in patients as well, isn't it?
I think another difference is, you know, some authors talk about muscles and ligaments, but we go deep into the nervous system and the cerebrospinal fluid, which I think is you know, it has a wider view than just muscles, basically.
Absolutely, couldn't agree with you more, Diego. You know, it's the basis of physiological control, isn't it? And
well, that's what Wernham used to say, that about the muscles are the most self-corrective tissues in the body. Yeah. So spending a lot of time on them when they're going to correct themselves, if we provide the right circumstances. It doesn't mean you neglect them, but they're the most self-corrective. You know, even if they've been torn.
Any more questions? Let me just get rid of that. Amazing. Thank you, Chris. Amazing. Thank you. A lot to think about. Yes, there always is in osteopathy. Always a lot to think about, and that's one of the great things about it. Thank you very much, Chris. Thank you. Many thanks from me, Martin Hoth.
It's a shame I didn't get that video to work properly with the sound, because what Werner was saying, and it was just so relevant, and he put it so beautifully and elegantly. So I'll have to, I mean, some of these videos we're just lucky to have because they were done amateurish, and we're lucky to have them.
Yeah.
So I might try and see if I can get that one done a little bit clearer in some way, even just put subtitles on it.
Maybe we can edit this webinar and add this video with the sound. So
yeah, nice. As they put subtitles onto the video, which would help. Yeah,
that's a good
idea.
idea.
I have the subtitles in Japanese, but not in English.
That makes it a lot easier for Japanese. I think most people can do that easily. Yes. Yeah, that's a good idea, because we've recorded it anyways, as you know. So
that series of we called Mechanical Gems was put into that series. There's 3 or 4 short videos that we put together in Wernham. It contains so much detail in just a few short pieces.
Yeah. All right. Any other questions? that anyone wants to ask? Is the video on the ICO website channel? It won't be yet, Caroline, but we will. I'm not sure if we're going to put it on Vimeo or onto YouTube. To be honest, we'll probably have a little chat about it, and then it will probably take a little bit of time to edit that video in, and then we'll stick it up. But I would have thought it's probably going to be next year, hopefully early part of next year before we get that stuck up somewhere. But I'll let you know when it's available to watch. Okay, well, thank you very much, Chris, again for spending your time and giving us the insight into your knowledge and insight into John Wernham's knowledge and Littlejohn's knowledge. And thank you for your help this evening, Diego. It's much appreciated. If you'd like any more further information about the upcoming webinar, hopefully that will soon be on either social media or our website, which I think is January or February, with Maria Kaufman, about booby traps, which is about how poorly fitted bras and tight bras can affect your health. And also our conference next year, which Caroline's going to be speaking at, and Mim is going to be there talking. Marika, Nancy Nunn, we had her on a couple of years ago, and she was amazing. Such incredible sort of knowledge. We've got Gilly Woodhouse talking about osteobiz and that sort of thing. She's fantastic at helping you get your business going. Sarah Wheeler, who went and studied under John Wernham at the John Wernham School of Osteopathy. Lucy Rayner, who specialises in tongue tie and that sort of thing. Did I say Alice Williams? I didn't say Alice Williams, and did I say Sandy Andrews as well? But if you go to our website and look at our social media, and we'll be forwarding more information about that soon. So I hope you all have a fantastic Christmas. Thank you all for subscribing and listening to our information that we put out this year. And we look forward to seeing you all next year. So I hope you have a wonderful Christmas and a happy New Year, and enjoy a bit of time off with your families. Thank you very much. Good night.
Thank you. Thank you for everybody.
Thank you.